Okay, we're going to take questions now. So if anybody has any questions they'd like to raise with Anita or the doctor, please feel free to raise your questions now.
Yay! Yay! Anita, thank you again, and I loved your comments to the ending about the freedom. That just was wonderful, and all your comments before that. And Dr. Sofair, yes, that was a really good point about everybody's an individual, so some people might honestly want to end their lives, but a lot of people, even though there's all these dire things going on to us, they still want to live. And that's what's important, is that it's an individual thing. And yes, I'm against the, state-assisted suicide. But thank you both.
Yay!
Oh, more questions? If not, I have one. In the back there? Yeah, come up here and raise your question.
I'd rather not. It's the alternative to the suicide, giving up eating. Okay? My grandfather took his teeth away, and I know of another person who did the same thing. So that's the only choice that we or they or you have if you don't have the drugs. That's my opinion.
I can comment on that.
Yeah.
Yes, repeat that.
So what the gentleman in the back said was that correct me if I'm wrong, as I paraphrase what you said, is that then the only option that people have is to stop eating and to die in that way if they don't have the drugs. And I think that's fine. I think that people are autonomous human beings, and people can make a decision to end their own life. What I don't think is a wise idea is have it be something that is sanctioned by the state, where physicians or other care providers participate in that process. I think that's a very dangerous next step. If I decide that, and we have this happen in the hospital, you have a patient that has advanced heart disease, and they have a pacemaker in place, or they have a defibrillator in place that can help the heart start again if it stops. And the patient has decided, look, I'm suffering, I have trouble breathing, and I don't feel well, and I've tried my best. And they decide that they want to turn the pacemaker off, they want to turn the defibrillator off, they stop taking their medications. Or the same thing with the patient that has cancer that decides they don't want to have any other chemotherapy. Those are fine. Those are autonomous decisions where people decide that they're going to let life take its natural course. But that doesn't require the participation of the healthcare system to help you do that, which I think is a very dangerous next step. That's my opinion on that. But thank you for bringing that up.
Yeah, great point, and I agree. It should be up to the individual.
You might as well stay up here. I have a question for you. We've had experience in my family, both with my wife Paula's mom and my mom, of how people get treated in the medical establishment and what it can sometimes do to people's individual psychology. In the case of my wife's mom, how old was Ruth when she was told that she was terminal for was it liver cirrhosis? She was told
when she was 58.
When she was 58, she was told
she had primary biliary cirrhosis.
Yeah.
Caused by her high blood pressure pills, and she was told she'd be dead by the time she's 70.
Yeah, so she was told that she was going to die, and that was 58, and she lived till 93.
Yeah.
So that is a pretty stark difference from what kind of thing can be told to a person at an early, what it made me also think about is even people who drift in the direction of feeling like they want to end their own life, how are these things evaluated by institutions in a way that looks at the whole picture? Because people can become confused in their own ways about what they should do, and it seems to me that there's not protocols out there that really analyze in depth the circumstances that lead people to make different decisions. And for me, this is just a simple example of how institutions don't have protocols. My mom was in the hospital seriously, she has serious Alzheimer's, and they had no protocol for even taking care of her in the hospital. The hospital was like clueless. When I brought her in, I said, she has severe Alzheimer's. She has hearing aids that are very expensive, and they need to take responsibility that those hearing aids don't get lost in the process of her being in the hospital. And they completely ignored that. Nobody in the hospital was talking to the maintenance people who work in the room where she is. The nurses just left food on a tray in her room. Nobody was actually feeding her for lunch or at the time that she was there. So even little things like that, there's no protocol for it. So how does a hospital or the medical establishment develop a protocol for really understanding the serious questions that somebody might have about deciding that they're not really, that they don't want to be here anymore,
So you brought up a lot of important points. I'll just address the one about the primary biliary cirrhosis, which, to start off with, which brings up again the issue that I raised before, which is we're not terribly good at prognosticating in terms of how patients do, and there may be treatment that becomes available as time goes on. I don't know if that was the case with your mother, where maybe more sophisticated treatment was available as she became older that allowed her to extend her life. So it's very important. We don't really know what's around the corner. To get to your second point, which I think is an important one, I'll just mention one thing with regards to that. So I trained at a very large hospital here at Yale, New Haven. It's an academic medical center. And then I went up to a very small hospital for a brief period of time and worked up there, Androscoggin Valley Hospital up in northern New Hampshire. It's about a 50-bed hospital. And what struck me about that, being in that hospital, is that the doctors and the nurses and the nurses' aides and everybody else, they're a part of the community. And when you're a part of the community, you know the families very, very well, and you know the way people act. And the patient has been in the hospital before, so you know that if you don't feed them at the right time, or if you don't get them to sleep by the right time, they're going to become confused in the morning, they're going to become upset, etc., etc. It's very different at a large hospital because patient A may be admitted to one unit for their medical issues, and then they get to know the nursing staff, etc., and then they go to another unit and they're admitted again, and people don't know them, so you kind of reinvent the wheel. So there's not an easy fix to that, of course, but at a large medical center where things are not necessarily as well coordinated, they can't be because it's very large. It's a difficult system to navigate. Sometimes those issues come into place. So what does a large medical center try to do to try and arrange that? Well, the one thing that we try to do is we try to now develop protocols which get to the point of what you're talking about. And I'm a part of our system's development of protocols. Now, it doesn't address everything that you ask. Most of the protocols that we develop are related to how you treat medical conditions, heart disease, how you treat an acute heart attack, how you treat heart failure, how you treat pneumonia, etc., just to make sure that people get relatively standard care. For psychiatric issues or existential issues, that's a little bit more complicated. You can't necessarily protocolize everything because people are different. They're complex human beings. What that does require is that requires time. It requires time on the part of the nursing staff. It requires that you care for the patient. It requires that you sit with the patient. And it requires that you have an honest relationship with the patient. Sometimes that's very difficult. We see patients that come into the hospital that are not from our socio-demographic group. They're very different from us. We're meeting them in the midst of an acute illness or an existential crisis. Who are they to trust me to sit and talk to me about these things so that I can get accurate information to then counsel them and take care of them? It becomes very difficult. And what you need to do is you need to just spend the time. That's the best that I can say. It requires a human touch. It requires that you're there with the patient and they trust that you are interested in their best outcome. And then they can open up to you. And I see it happens very, very quickly. If you take the time and you sit at the patient's bedside and you sit and you listen to them and you look in their eye, then, and they realize that you're there for them, then it opens up. You can't protocolize everything, but that's a start. The one thing that I will also say, it's made much more difficult by COVID. I have one of my neighbors whose daughter is a master's student at a university down south and has had anxiety and PTSD and obsessive compulsive disorder through her whole life, and has more recently been very ill, mentally ill, to the point that she's been hospitalized a bunch of times. They wanted to bring her back up north because they're from Connecticut, but what they found was that a lot of the ongoing psychiatric care is virtual now. And that just, COVID has made things a lot more complicated in terms of the assessment of patients, especially the assessment of patients that have mental illness, because a lot of it is not done face-to-face. A lot of it is now done virtually, and some of you may get some of your care virtually. And it's also made more difficult because we're in the room with the patient, we have a mask on, we have goggles on, they can't see our faces, they can't see our facial expressions, we can't see their facial expressions, and sometimes the mask muffles our voice. The only reason I bring up all these things is medical care is very complex, and medical care, as I'm sure a lot of you have already experienced, it depends on who your providers are. You click with some and you don't click with others, and you may get somebody that's very good and you may not get somebody that's very good, and a lot of that is left up to chance, unfortunately. So I think your question about how you try and make things more standard to try and limit variability is very important. I don't know if that addressed all the questions that you raised. If I didn't, I can try to clarify other things.
Well, I think the one thing that was an issue for me still was the one thing that was sort of an issue for me still was in the case of people who have very severe mental issues, like in terms of like an Alzheimer's patient. There's no procedure in that for that particular group of people in a hospital situation that would address the kind of needs that they have, because an Alzheimer patient is not going to feed themselves. An Alzheimer patient is not going to know how to do anything, and if a person comes in there who's a nurse or an attendant or even a maintenance person, they all should have the same understanding that this person is not somebody who you can talk to and tell what to do. And on that basic, simple level, my question is that creates an environment where hospitals need to have a specific procedure for dealing with people with that kind of specific kind of different condition.
Okay, Anita has something to say, and then I do too.
I could just comment. I do agree with you on that. I think that I think we try our best at that. We have a geriatrics unit at the hospital, Yale New Haven, that I think does a better job of that than all the general medical units do. I agree with you. I think we need to do better in that, and I don't think we always address things as well as we can with that. So I take that, and I'll take that back with me. And I manage a general medicine unit. It's a 24-bed unit at our hospital, and we do have these committees where patients and families and providers are all together to try and solve some of these issues. So I appreciate that. Thank you.
I'm going to say that your question resonates with me. And the reason it resonates with me is that, and I understand, for you, Dr. Andre, your response, but I think this also, because I noticed this is not just people with Alzheimer's.
Yeah.
If you have a person with so my dad, back in the 90s, had a massive heart attack, which resulted in a global brain injury. So he went from being a handyman and everything of the family to very severe disability, depending on everyone else for his care and all. And there were times when he was in the hospital where, and then if you have a brain injury, and sometimes you can be, brain injury affects people in different ways. So, here it is, we had a situation with my dad where he couldn't communicate.
Right.
And that's the thing, is that a lot of medical personnel are not trained in dealing with people with disabilities as human beings. That you have to be in a situation. I've been in and out of the hospital these past few weeks, and I've had people come to me with just like, oh my goodness, are you kidding me? And the thing about it is, they don't know disability. They're not used to disability. They're not used to dealing with people with disabilities. They think, for instance, I just started using insulin, and I have very low vision. I'm past legally blind. I have pretty much no usable sight. And so they were going to try to teach me how to inject my own insulin. And I remember talking about this, the provider said, well, yeah, I know you're disabled and y'all all want to be treated alike, so that's what we do. And I said, wait a minute, stop. This is dangerous. We want to be treated with equity, but we learn different. Our disabilities factor in to make things different. You can't use a cookie cutter approach to people with disabilities. And I noticed that I'm privileged in that I can speak, and I can speak for myself. I'm a disability rights and justice activist, and so I make things well known. I wind up fascinating a lot of people, a lot of the doctors and everything like that. And so, I get treated kind of halfway decent, as much as racial disparities and disability discrimination allow you to be treated. But when you have people with disabilities, whether it's Alzheimer's, whether it's a person has a communication disability, because that happens too. If you don't communicate very well, people turn off on you. To me personally, I'm sorry, but all this stuff needs to start in medical school.
Yes. Yes.
It's not for the doctors to get there on their first rotation and find somebody. This needs to start in medical school. And the teaching in medical school, sorry, it's got to be done by people with disabilities.
Yes.
It's got to be done by those of us who experience the problems, who are at the source of the problems, and all to explain. Now, there's some organizations that are kind of doing that now, that they're inviting people with disabilities to come and speak, to their med students, or speak to medical providers, because the problem is that things with people with disabilities are so medicalized. Everything is about a sickness or a condition or anything like that, and the thing that we have to realize is that we're not sick.
Right.
There are those of us that have significant or severe disabilities, but we are not sick.
No.
We're healthy within the confines or whatever of our disabilities. But to me, it's you got to have a whole new sea change, because that very study I talked about earlier, about 82% of doctors feeling that people with disabilities had a lesser quality of life. There's a significant number of doctors who don't feel comfortable working with people with disabilities.
Right. Don't want to touch
And
it.
that's from biases, whether their own, from societal biases around people with disabilities. But your question resonated with me because I saw with my dad, I saw with another friend of mine who has communication issues, and whether it's from Alzheimer's, whether it's she has cerebral palsy, and so she has speech difficulties related to that. But then people assume that we're They assume incompetence when you should assume competence, that we know ourselves and we know our body. One of the things that happened with my dad in a nursing home, and we wound up in a class action lawsuit that we won, was they came in and they put food near my dad but didn't bother to feed him.
Mm-hmm. All the time, all the time.
They gave him his medications from a communal container of yogurt that they went and spooned in, put the pill, and went to him, spooned in, put pills to next patient, and all. This was in a nursing home. And so, but the thing about it to me is you got to recognize the humanity of whom you're dealing with. And I don't think that the medical schools have, that's something that they need to teach you from jump, that they need to teach you a basic, how do you deal with people who cannot communicate, who have communication issues. They can make protocols like that. They can figure out a way, how do you communicate with, it's like my wife goes into the emergency room, she's deaf. A lot of times they don't want to get her an interpreter. They're supposed to by law. But oftentimes they just run their mouths, and luckily she can read lips, kind of, but it's that thing, they don't teach you how to deal with people with disabilities because they still have that mindset that you probably won't run into somebody. I went to 2 years of medical school at University of Illinois, Chicago Circle. And once my disabilities started getting out of control, losing more sight, the seizures getting out, this was pre-ADA, pre-Americans with Disabilities Act, so they kicked me out of med school. Sorry, find another career path. Now there are more and more people with disabilities who are entering med school, but, they're still not, it's still a trickle. It's still a trickle. So I say all that to say, number one, the doctors have to see, and they have to be taught in medical school to see people as humans, to see people as not just problems to be solved. There's a way that you can have a simple protocol to deal with someone, that you can generalize, that you just don't go and put some food out there. You come and see later that someone hasn't eaten their food. What, you don't read their whatever is to say this person has Alzheimer's or this person has a severe disability and they can't feed themselves or this. So yeah, let me stop.
Oh, honey, I got something to say here.
Thank you for that, Anita. That definitely resonates with me too, because that's what happened to my mom. She never got her lunch because they just put it in the room and they didn't even give it to her, and she couldn't even speak or really explain it to people. Anyway, got more questions, but let's hear from Elaine.
Please realize we all have so much to learn about human beings. The real question is whether or not enough people will realize that people with disabilities are human beings. It's still not something that a lot of professional people believe. And they show us that consistently. Now, until September 30th, 1977, I was abnormally physically healthy. I had other disabilities that you can't see that were quite significant, by the way. But I'd never been to the hospital except to get born and get my tonsils out. I never even had a broken bone. I had nothing serious until September 30th, 1977, I got stabbed in the back. Yeah, that was just a couple days ago now. For those of us who acquire significant disabilities by something dramatic and traumatic, we've come up with a term. So September 30th is my rebirth day. I'm still Elaine Kolb. And yet I'm also a whole different person. And a whole lot of people who acquire significant disabilities want to commit suicide. It's just a fact. And a lot of non-disabled people actually are not aware. I wasn't aware. I thought I had nothing against handicapped people. I liked, because that was the term we used back then, of course. And, you know, and I believed everybody had all equal rights. And I didn't know. I did not understand that living in a toxic society, we acquire the prejudices of the society that we live in. And so I also was infected with ableism and disabiliphobia, the fear of disability. I didn't know until all of a sudden it was me. And I was very athletic. I was very strong. I could run. And then after that happened,
may I have your attention, please?
oh,
The Newport Public Library will be closed in 1 hour.
okay, thank you very
The
much.
computers will shut down.
Yes,
Thank
okay.
you and enjoy.
Thank you very much. Yes, so in 1 hour it will shut down, so we are still here and we're not dead yet. So, this is the thing. All medical workers, all social workers, all teachers, and all human beings, we need to learn about the culture of people with disabilities. It's a culture. And it's a multifaceted, we are everyone. And we're you too. Everybody, we're the largest minority, but we never get listed with the other minorities. It's still pretty rare to get listed, you know. But we're the largest. And we include everyone. And not only do we include everyone, but it's a minority at any one time. But if you look at the lifespan experience of human beings, it's a majority experience. And if you don't get a disability yourself, someone you love will. It's a majority experience. Before you die, it will affect you. Why won't you study it? Why won't you acknowledge that our lives have value? That we offer everything. And we are everyone. We're you. You're me. That's the level that we need to address this at. And so if you're involved in medical education, you can help set it up. I volunteer. I do it. I'm doing it right now with a physical therapy program. I'd love to come. I love to come to schools. I love to teach people. Anita, she's great. There's a whole lot of us out there. We're the veterans. We've been through it. We know how to interact. We know how to discuss, and we love teaching. But we do want to be recognized as real human beings, and that it will be interchange, mutual giving in exchange. And everybody can benefit, and we'll end up with a lot better, more humane professionals. And you can help to make that happen. You do education. Yes! Anyway, am I excited? Of course, you know me. Yep. So, you gonna bring us?
Okay, are there more questions or?
Questions, statements, comments?
Okay. Yes, I know.
Maybe we should have everybody sit down,
Yeah.
so we wouldn't have to keep doing this.
Okay,
Right to the point.
all right. Okay, so I have so many things going on in my head with this discussion. I want to thank you, Doctor, for coming. I worked in healthcare 42 years, 36 of them in a geriatric setting, nursing home. And to address your poor mother, who I knew well, when I first started working, we had something called patient care report. Every single day, the nursing staff had the time to sit down with the previous staff, previous 8 hours, and discuss what happened and learn about the patients that they were going to then take care of for the next 8 hours. That doesn't happen anymore. And this is where you could really help, because you do work for Yale, and Yale now owns everything. When I finished working, we would tape record our reports into a tape recorder that the next shift came in and listened to, and then the nurse would go out and try to find the aides to tell them what to do. Well, by the time you actually got out there to find the aides, the breakfast had already come, the patients have already been sitting there, it's already cold, they don't know who's new or whatever. Nurses need to give report verbally one-to-one. It's just insane that they took that away from us.
Yes.
I do have an actual question, though. I want to know if, God, it went out of my mind. When my mother-in-law was admitted to the extended care facility in New Jersey, I made out with her, sat down and did a 20-page living will. Before she could be admitted there, they wanted to know everything. Was she going to have an antibiotic if she got an ear infection? I mean, it was so detailed. And I had the privilege of filling that out with her. If we all had extensive living wills, would that prevent the state from taking over and control? Would that help at all? Because I think if it did, that's where our education should be. Get people to do extensive living wills so people know. Because the gentleman left, that was the other point I wanted to make. One of the things, when St. Raphael's owned us, they were very big into this idea that everybody had to live as long as possible. So at one point in that little facility, we had like 20 people with G-tube feedings. These were people who couldn't communicate in any way, but who's were told by our patient care coordinator that you don't want them to starve to death. You don't want them to be thirsty. Oh no, we have to put this tube in them because otherwise they'll get pneumonia if we try to feed them. And we would go to these people, and I always gave them what was ordered, but they'd be crying because they couldn't communicate anymore, and they didn't want this thing. They didn't need this. They should have been allowed to die with dignity, and sometimes that doesn't happen because medical ethics or whatever goes the wrong way. People don't have to live forever. I think maybe that's all I had to say. So I don't know if it was articulate, but
Gotcha.
you heard.
Okay, come on.
I actually was supposed to leave about half an hour ago, but So, yes, in answer to your question, living wills have to be honored. It wouldn't necessarily address this. This is kind of a separate issue, but I think that since your experience at St. Raphael's, which is where I work on that campus now, I think people are becoming a lot more comfortable not putting in G-tubes, by the way, and letting people.
Yes, so definitely. That has
Yes,
changed.
definitely.
Yes.
I think we try to counsel people not to go in that direction. So I would like to take you up on your offer.
Yes.
So I'll get your email, but
Absolutely.
we unfortunately, with COVID, we're not allowing people to come for education, but if you have a card, I'll send you
I
an email.
Zoom all the time.
Oh, okay,
You can Zoom
great.
me in.
I will. I'll see what we can do in terms of having a conference that's relevant. I think that would be really helpful. I don't know, you had a comment you wanted to make?
No, I just have a movie recommendation. I was recommended to watch Netflix Crip Camp, which I found very helpful and.
Just one last question on the protocol thing. It might have slipped out of my when I asked it. I just wanted to know if maintenance people are considered like medical staff, because that's one of the problems I found with my mom's case, is that when people are, I don't feel like the people who do the cleaning and the maintenance in the rooms are on the same page as the rest of the staff, or if they are knowledgeable about patients. So, and I sort of feel like that those kind of people should be really considered medical staff as well, because they interact all the time with the patients. And in my mom's case, that's how her hearing aids were lost, because they just stripped her bed without recognizing that this is an Alzheimer patient, and that it's very likely that her hearing aids are not in her ears and are in the bed. And actually it happened twice. Luckily, the second time it happened, my wife and I were actually there, and I said, wait a minute, don't take those sheets out of the room. Look inside those sheets, and sure enough, inside the sheet was one of her hearing aids.
I can tell you what they did in the nursing home section of, which is now the Grimes Center is where I worked. You had the aides and dietary delivering all the food now, and the cleaning people helping to pass the trays out and everything. And the nurse hasn't got time to tell any of those people anything. Mm-hmm. So, and I think sure that happens in the hospital too. And they've got dietary aides dropping off trays, picking up trays, and whoever they can, the aides do clean, change the sheets and things. But no, there's no time. And it's because they're so short-staffed. There used to be time to do these things, but they keep cutting the staff and keep adding responsibilities to it. Licensed staff has so much more time they have to spend filling out all the computer, checking all the boxes on the computer, because everything's done by computers now. And that's time you take away from actually talking to your staff, telling them what to do. When Stan's mother had a stroke, we went to the facility. Now, this is an assisted living facility. Mm-hmm. So we knew she wasn't getting a lot of care.
Yeah.
But we arrived there, and she needed to go to the bathroom, so we asked for an aide to come in and help her to the bathroom. And the aide comes in and says, okay, come on, Helen, we're going to go to the bathroom. I said, no, she can't walk. Oh, yeah, she can walk. No, she can't walk. That's why we're here. She had a stroke yesterday. Oh, no, she walks fine. She walked with me 2 days ago. Nobody had told the aide taking care of her now that she had a stroke, because there was no time, no communication. I don't know. But I think it's lack of time. They just don't have the time to make the communication. And that's what has to change. And there has to be more time for staff, all levels of staff, not just the doctors. We can't just blame it all on the doctors. We can't just blame it all on medical school, because it's nursing school too. They've taken nurses, and instead of them learning hands-on things, now they have to learn telemetry, they have to learn all the computer stuff, and they've taken away the actual hands-on stuff, which is what people need, especially in any kind of extended care facility.
Absolutely.
You need the time to learn about the patient. And that's my... Woo!
Anita, you want to go? Or no? Yes, no?
Yeah, I'm gonna go, but I don't know an answer to your question. I don't know how they're trained.
Okay, thank you.
Yeah, I'm not part of that.
Is what I did.
Thank you. Thank you very much.
Thank you so much, Dr. Sofair, for coming and staying longer than you intended to, and sharing. Thank you. I feel like I want to bring this back around because what people are talking about and have been for the last, I don't know how many minutes, but is the broken medical system.
Yes.
And in fact, it is broken.
Totally.
And we now want to introduce medical-assisted suicide into this. I find that absolutely reprehensible and incomprehensible. I don't understand if anybody has experienced this system the way many of us have here, how you could even begin to think that this is a good idea. I think many of you know my experience with my mother, who began to have a series of strokes when she was 70, which is very close. I'm just a few years short of that age now, and ended up with what was diagnosed as mixed dementia, including the vascular dementia that came from the strokes and the dementia from Alzheimer's. They weren't really sure about the Alzheimer's, but it does seem to that there was an additional factor there. In any case, by the time she was in her early 80s, she had dementia. And she had repeated visits to the emergency room. She ended up in a nursing home in 2007 because I could not take care of her at home any longer and work. Those are the kinds of lack of support that caregivers get in this medical system. In any case, she ends up in a nursing home, and she ended up with repeated visits to the emergency room for a variety of things. The first time I encountered the attitude of the medical system toward the elderly and and people with dementia was during, I think, maybe her first or second medical emergency room visit, when she had been taking on some new medication and was confused and was having heart palpitations. And a doctor, and I said, well, she's been taking new medication. They should probably try to figure out, which one of her medications may be causing this. And the doctor said, oh, society can't bear that cost. That's too much. That's too expensive. And you shouldn't be asking it at her age. You should just let her go. Now, he didn't define what that meant. Mm-hmm. It turned out that in this case, she had an easily treatable urinary tract infection. Now, since then, I have learned that with the elderly, the first thing you look for, especially somebody with dementia, is, okay, maybe you have a urinary tract infection. In any case, she had repeated visits for numerous things, and she ended up in the hospital in 2011 and was there for about 6 months. And the cause was that, one of the many causes was that she basically could no longer swallow. And this was a result of possibly a combination of esophageal problems and also her mental state. And the body actually forgets how to do certain things. So they did not want me to pursue treatment. She did get a feeding tube, which we hoped would make a difference. But I was, and then it became clear that she also was having trouble just swallowing, period. So there were a number of discussions about, well, what should her treatment be? But throughout this entire time, I was subjected endlessly to relentless, never-ending pressure from numerous members of the medical staff, including nurses, some doctors, even some of the technicians, that I should just let her go. Send her to hospice, give her morphine, and let her go. Now, meanwhile, my mother is saying to me, I don't want to die, please don't let me die. They attribute this to her dementia. And I know my mother. Many of you here also know my mother, and she said that repeatedly. I was doing everything I could to try to get her the kind of treatment that she needed at that point in order to be able to live long enough to know that she was not being thrown away by this society, this throwaway society in which we live. She got that treatment, but only after I had been browbeaten for months, told that I was unrealistic, I was selfish, that my mother was suffering, blah, blah, blah. Just let her go. Finally, because of a few good doctors who did support me, she did get that treatment, and she lived another 6 months. And she ended up in the New Britain Hospital for Special Care, where I was able to actually, I lived with her in the hospital when all this was going on. I was told when they were all ganging up on me to try to get her treatment ended, not only was I told all of this crap by the medical people, but I was also told repeatedly by hospital administration, her treatment is costing us too much. They didn't even bother to couch this in any niceties. Her treatment is costing us too much. My mother was on Medicare and Medicaid. Now, into this system, you want to introduce medical-assisted suicide? I don't think so. Where is the understanding that this is an existential threat to anybody who has ever been marginalized? And as Elaine and Anita have described so beautifully, we are all going to be disabled if we live long enough on some level. We're all going to be marginalized. Do you want to live in a throwaway society, or do you want to live in a society that takes care of everybody? That gives everybody a chance and an opportunity to live? You know as well as I do, or it should be, I think it should be obvious, that medical-assisted suicide in terms of throwing people's lives away. To make that legal provides nothing in terms of health care. It simply is an existential threat to all of us. It's that simple.
What we're finding at Not Dead Yet is that people who have living wills generally don't get their wishes met. Also know that if you're someone with a disability, you may find out accidentally that you have a DNR in your records, so do not resuscitate. And they do this to people with disabilities most of the time without their knowledge or consent. And if you have intellectual disabilities, you're even more likely to have that done. So often, people try to get pushed toward assisted suicide, and let me tell you something that's really messed up. So when you die, on your death certificate is usually put your immediate cause of death, and then an underlying, sometimes in some states they have an underlying condition. With these assisted suicide laws, they're not going to put, they don't put, drug overdose by suicide or whatever that's supposed to be put. They put the person's underlying condition, pancreatic cancer, lung cancer, breast cancer. So they lie. They falsify documents. That's what that's, a lot of people don't realize that that's These laws are made up. You know, they're designed to hold people immune from prosecution. In these laws, notice how proponents say medical aid and dying, death with dignity. They don't want to use the term suicide, and which that is what it is. If someone takes their own life, that is suicide. But they don't want that term used. But that's what it is. And here it is, we have a society that throws us away. We have insurance companies, everything. It's all about the bottom line. And don't be poor on Medicare or Medicaid, because you're just a useless eater, eating up our system, and how dare you want, you know, a good, you know, effective medical treatment. So there's so many reasons why assisted suicide laws, doctor-assisted suicide, I never use the euphemisms, and often in my testimony I'll say I'm not going to use the euphemism that you use to describe this bill. This is doctor-assisted suicide, and it's dangerous. It is a deadly form of discrimination.
Thanks, Anita, Elaine, and everybody else for all the great comments and for putting on a really good program. I'm sorry there aren't more people here. We'll have to get the word out in other ways and continue on, but I'm glad we got this program together today. All right, thanks to everybody.
Well, ever do it again, I'm more than willing to come back. Hello, I get to sing.
Wait a minute.
Hello,
I forgot a very
sing.
important part of this program.
Hello? You're not gonna get past me, honey. I love you desperately, but, you know, we're not dead yet, and I got the song.
We're not done yet.
No, we're not done yet. Oh, that's okay, relax. Whoops. I know, it's always interesting. Yeah, I can move this way, that would help. You know, we're in this together, we're like figuring out. Once we get it all together, 96, I wrote the first verse and the fourth verse. And I've been thinking about it, and I said, Elaine, you have such a hard time. But I remember the first verse and the fourth verse because they used to be the whole song, plus the chorus. And the verses 2 and 3, I can't remember. And you know why? Because I got older. And my forgetter is getting better and better. So I have a hard time with those. But you'll sing Not Dead Yet with me, right? Okay, all right. Anyway, do you have the words, everybody? Are you ready? Ready. Okay. Well, we're not dead yet. And we can boogie with the best of them. We are not dead yet. And we can laugh and have some fun, 'cause we're not dead yet. And we're fighting for our freedom, and we'll never die, 'cause our spirit will live on. Now the outcasts of the outcasts become the leaders of today. The ones we used to throw away to die are teaching us a better way. Well, I'm positive if you're HIV, you can understand the song. The last will be first and the first will be last, and there's more than one way to be strong. 'Cause we're not dead yet, and we can boogie with the best of them. We are not dead yet, and we can laugh and have some fun, 'cause we're not dead yet. We're fighting for our freedom, and we'll never die, 'cause our spirit will live on. Well, when you take away our services, we don't know how we'll survive. Death is cost effective. Do you want us dead or alive? Sometimes I wonder about that, don't you? Well, when you take away the things we need, we don't know how we will cope. When you cut our means of security, you take away our hope. But we're not dead yet, and we can boogie with the best of them. We are not dead yet, and we can laugh and have some fun, 'cause we're not dead yet, and we're fighting for our freedom, and we'll never die, 'cause our spirit will live on. Well, if Medicaid does not aid us, if Medicare does not care, millions of us will suffer. How can you believe that's fair? If you want to cut that funding, stop the welfare for the rich. Billions bail out the billionaires. We're trapped down in the ditch. And I think if you're brave and you want to, I know we're supposed to social distance, but I think it would be really cool if you wanted to come up here. Because you know what? We are not dead yet, and we can boogie with the best of them. We are not dead yet, oh yeah. We can laugh and have some fun, 'cause we're not dead yet. And we're fighting for our freedom, and we'll never die, 'cause our spirit will live on. Well, it's a battle cry for freedom, through the healing power of love. It's the hope we share from our visions deep inside, up above. It's the peace that comes from the struggle to be as brave as we can be. We are proud and we are humble, and the truth will set us free, 'cause we're not dead yet. Dance! 'Cause we can boogie with the best of them. We are not dead yet, and we can laugh and have some fun, 'cause we're not dead yet, and we're fighting for our freedom, and we'll never die, 'cause our spirit. Grand finale! Oh, we're not dead yet, and we can boogie with the best of them. We are not dead yet, and we can laugh and have some fun, 'cause we're not dead yet, and we're fighting for our freedom, and we'll never die, 'cause our spirit will live on.
To check out the
Oh, yes, they're closing the library, but we're not dead yet. Thank you. And thank you, everybody. Yay.